We are going to move on to Dr. Davis, who's going to help us dive even a little bit deeper into some of the detailed points about providing supervision in virtual patient care. Dr. Davis.
Thank you so much. All right, so I'd like to talk a little bit about maybe some of the theoretical backing and some of the best practices and evidence that we have that we put together around resident supervision. Next slide. So oftentimes, because we may be new in the Southern Ontario environment to virtual care and learning it ourselves, oftentimes we may think, well, how could we possibly fit learners into this milieu? Virtual care is new to us, but it has been happening in other settings for some time. Australia, Northern Ontario, California with the University of California, and San Francisco with Kaiser Permanente have been pioneers and have some literature speaking about how medical learners fit in. Really, I think one of the ways to think about the virtual learning environment is that it is somewhat similar to our clinical learning environment, meaning that we need to establish a learning environment. So what do you need for a learning environment? Well, today I'm going to break the learning environment into sort of 3 buckets to talk about. Recognizing that in the medical literature, it's rich talking about sort of other aspects of the learning environment. And I mean, that's absolutely a place for further study if people are interested, thinking about those other aspects of the learning environment. But for today, we're going to talk about 3 aspects. So one is you need a knowledgeable teacher who's familiar with best practices. And I think we talked a little bit about how medical virtual care is evolving. I'd put a plug in, and you should have all received a reference list. If not, my slides are referenced at the end. But I'd put a plug in for the Virtual Care Playbook, which has been published around the same time, actually in March, when the pandemic started. It wasn't published for the pandemic. It was actually set to be published, but published from the CMA, OMA, the College of Family Physicians, as well as the FRCP group, that really sort of looks at best practices in virtual care. So if you're becoming a knowledgeable teacher, familiar with best practices, that's a great resource for you to access. So knowledgeable teacher, familiar with best practices, which you are becoming by virtue of doing and by virtue of learning. We need to select then appropriate patients, and I'm going to spend a little bit of time talking about that. And then we also need to provide appropriate structure and support for learning. So we'll spend some time doing that. Next slide, please. So when we think about appropriate patients, I think of them in 2 sort of groups. There's the operational, so how do you get the patients into the schedule? And then there's the learner considerations. So let's talk a little bit about the operational perspective first. The operational perspective is that piece that gets patients into our schedule in a way that makes our days satisfying and safe. And in order to have a successful virtual encounter, patients need to be able to participate in virtual care. People who are going to help us with this are going to be our administrative team. They're going to be valuable in helping establish if patients have the technology, or if we can get the technology that they require to them through a variety of ways. And I think the next evolution in virtual care will be thinking about how to enable our patients, recognizing that not all patients have the ability to access the technology required, whether you be here in Flamborough, where I am right now, and a kilometer down the street from me does not have high-speed internet. So many of our rural places may not have access to the broadband speeds that they need. You need some degree of digital literacy. You're going to need someone who can help if there's language barriers, either a facilitator or a family member for the patients. And an ability to understand instructions, because communication is different in the virtual world. And we've all had Zoom meetings and you're exhausted at the end of the day. And it's because some of the cues that we're used to picking up on, those body language cues, those pieces that help us facilitate the day, may not actually be as able to be picked up through the virtual world. So you're going to use your admin staff to help you decide or help screen to see if patients are appropriate to be with your learners. And I would also argue that, as clinicians who have continuity, many of us have continuity with our patients over time. You may be able to look at your screen, your day sheet, and you should look at your resident's day sheet as well, or medical learner's day sheet, because you may actually recognize that there may be patients who screen through and are booked appropriately, but may not actually be appropriate for virtual care. So doing some advanced planning and looking at the day sheet will be helpful. Remember also that continuity in relationships enhance our ability to care and understand for our patients. And as seasoned clinicians, we've often developed these relationships over time. Our learners may be new to our clinic, and sometimes that patient context, much less in the clinical setting, can be so important for learners to help with understanding a patient and establishing that rapport and therapeutic alliance, because again, that communication in the digital world is a little bit different, and establishing that therapeutic alliance can be a bit tricky. So again, looking at that day sheet and providing context to our learners about our patients can be helpful with respect to their communication skills and the success of the visit. Next slide. So then that's the operational side. There's also then the learner considerations. So those are sort of two big buckets. So first is sort of that level of entrustability. Where is your learner with respect to their skill spectrum and their competencies in the domain in your clinic that they're in? So for example, you'd want to place a novice learner with fairly straightforward presentations. So for example, in family medicine, we might, an uncomplicated UTI, as opposed to a UTI in someone who has had bladder surgery and has chronic hydronephrosis and is unwell, because you would want them, much like in the clinical setting, to be set up for success and safety. Also the level of supervision, and there's a bit of a trick to that. In the virtual world, recognizing that in the virtual environment, certain roles, like the communicator role, might be a little bit more stretched than it might be in the clinical setting. So for example, the ability to read patients, to reflect back, there may be gaps because of broadband pauses. Those may be challenges that may stretch a novice communicator into a place where you would want to have enhanced supervision. So thinking about that as you sort of set up the day. Next slide, please. I think it's also important to frame for our learners that transitioning to an in-person encounter is not a failure. That is expected in virtual care. There are times when it should and will happen, and it should not be seen as a failure on their part to not having completed the virtual visit good enough. Obviously, one of the key elements that 10-Kate identified for entrustability is humility, and that's knowing when to ask for help. Given that learners have varying experience with virtual care, they may not recognize when something is not amenable to care. So it's really important to discuss this explicitly with learners and how to transition to that in-person assessment. Both you and the learner need to discuss a contingency plan and backup plan for when these encounters need to transition. For example, if the patient appears acutely unwell, having the learner understand that they may need to transition via calling EMS and understanding safety around that. So if a patient is acutely unwell and is in their home and requires transport to the hospital, not hanging up on them, not ending the video chat to get them help, but rather staying on the line and activating EMS may be important, while having a sideline conversation either via text or having a supervisor join them in that chat. So having that conversation for safety beforehand is so important. It's also important that residents and learners understand where their supervisor is and where the patient is geographically with respect to them. So for example, you might be in the same clinic, you might be in the same cubicle, socially distanced, you might be in the same clinic at either end, or you might be at home, your learner might be at home, and the patient may be in their home. And understanding the geography of that may be important if you do need to transition quickly to an in-person encounter. Other times you might need to transition less acutely might be if the person requires a physical exam. So having discussed with the learner, where is the next place to place this person, or how are you going to review to do that? and if the patient is having difficulty or the resident is having difficulty following the telemedicine visit. So next slide, please. So thinking about that difficulty following a telemedicine visit, it may be important to talk to your learner about bedside manner prior to them starting their day or their clinic with you. So bedside manner is much like bedside manner. These are the communication skills that we use to help ensure that we have a successful visit. So you want to be in a secure space, meaning that health information isn't going to be transmitted or shared with others without patient consent. You need to have some good lighting, a professional background, good quality camera, speakers and headphones, and setting the camera up so that it appears like you are looking at the person. So having the camera in front of you so that when you're talking to the person rather than looking off to the side. Having a professional appearance, attentive body language, not looking like you're documenting while you're talking to the patient, and eliminating noise and distractions if possible. Next slide. So I think I was...
Yeah, sorry, Dr. Davis. Maybe we'll just take a short pause there to see if anybody has any burning questions. We could do 1 or 2 questions for you before we move on to your next section. I think what I'm hearing you say is that when we are beginning with a resident who may be new to virtual care, before we kind of have them jump into those virtual visits, there's some things unique to virtual care on which we need to be instructing them. And those are things that you've reviewed. And it sounds as though additionally, setting up a plan with them before they go into a virtual visit for those situations where there may be an emergency or an unexpected challenge. So it's important to plan with the resident before beginning the virtual visits. Is that fair to say?
Absolutely. And I think recognizing as well that up until this pandemic, most of us weren't in Southern Ontario providing this type of care, nor was it covered in a robust way in the undergraduate curriculum or the postgraduate curriculum. So residents may have experienced it during the pandemic. If they're a new resident or an undergrad student, this may be their first time with you doing virtual care. So, you know, we'll talk a little bit about that in the structure and supports piece, but understanding that even though it may be a senior learner, this absolutely may be a new skill for them, and that may govern the type of appropriate patient that you may pick for them.
That's very helpful. I think we have one question. Dr. Backer actually has a question for you.
Yeah, this one was actually put in the chat by someone. And the question is, there's 2 questions, they're kind of related. But for a phone visit, do you do a 3-way call and listen in while they're speaking? And similarly for OTN, one question about OTM, do the residents need their own account? But also, do you do 3-way visits with OTN? It seems that it might be, you know, less efficient that way.
Yeah, so actually I'm going to talk a little bit about that in my next section. So I may hold those questions
Okay,
because we're going to
thanks.
talk a little bit about structures and supports and some ways that we might do that in the next section.
Great. Why don't we go ahead then, Dr. Davis?
Perfect. So just to reorient us, next slide, please, as to where we are. So thinking again about that learning environment. We've talked about the appropriate patient. So let's talk about structure and supports. So if we think about the virtual care playbook, it outlines the components for the effective virtual visit. So acquiring consent, documentation, and closing the visit are sort of the 3 big headings in that virtual care playbook. If we modify this and we think about how to create the structures and supports for our learners, I would insert learner needs assessment at the beginning, and then providing feedback with the closing the visit piece. Today, we're going to talk about that learning needs assessment and how to structure that. The feedback and evaluation is actually going to be covered in a separate talk that'll be happening on July 23rd, so we won't really be getting into that today. So next slide, please. So before I go on, there are three really great resources that are in my reference sheet that anyone who is supervising a resident, look these up, print these out, have them by your hand. Really, anything I'm going to tell you is are on these three sheets. So the one is from the family medicine, the College of Family Physicians, supervising family medicine trainees in a virtual environment. There's also a great handout supervising learners while providing virtual care from NOSM through their continuing education program. And then the telemedicine, the essentials by Herzl was from the University of McGill. All three of these are excellent resources and will really sort of walk you through anything you might need to do with a learner. Sorry, next slide. And there's a picture of them. Next slide. So when we're thinking about the learner's needs assessment, like I mentioned, virtual care is new to many, if not most of us in Canada. The same can be said to our learners. And there really was that quick pivot to virtual care during COVID, and many of our learners may be participating in virtual care for the first time in their medical training, and it may not have been covered in their undergraduate curriculum. So thinking about learners' needs assessment, first and foremost, we need to make sure that they're familiar with the platform that we're using, and remember that not everyone is using the same platform. So in some clinics, people are using OTN, some clinics, people are using Babylon, some clinics, virtual health, some clinics are using DoxyMe. So the resident may actually have been doing virtual care, but not with your platform. So sitting the resident down before they start, show them the ins and outs of your platform if they're not familiar with it, and make sure that they understand the technology requirements so that they have headphones available to them if they need them. They've got the broadband, and again, even in Southern Ontario, don't assume if your resident's working from home that they have access to high-speed internet. Connectivity and troubleshooting should they get into trouble with respect to the platform. It may be appropriate to share with them the virtual care playbook as some pre-reading if they're not overly familiar with virtual care. And that playbook, for those of you who haven't seen it, it's not long. It is 5 pages. It's readable. So again, talking about patient safety considerations, thinking about where your patients are geographically, how to transition, and having a backup plan for technical failures, both for patient encounters. So what happens if the phone cuts out? What happens if you can't reach the patient, as well as supervision? So what happens if you text me and I don't respond because I didn't go through? Is there a backup number? Is there an email you can reach me at? Finally, discussion around supervision should take place in a supervision approach. And we're going to talk a little bit about this. But much like us in most of our training that we do with learners, we have an apprenticeship style opportunities which involve role modeling, scaffolding or frameworking, and coaching and observation. So for example, a junior learner who's never experienced virtual care, it may be very appropriate for you to just do some role modeling, which means having them join you on some visits as a starting point. For a more senior experienced learner, you may be doing some coaching for competency, and you may actually choose to do direct observation or case discussion and chart review. Next slide, please. So if you're going to be doing direct observation or case review, again, you're going to want to schedule your day perhaps a little bit differently. So this is an example of a wave schedule that you might use for supervision. So the original physician schedule is on the far left. So thinking that you may want to start your resident, which is on the far right, seeing patient 1 and give them some additional time while you see patient 2. And then go back to review patient 1. Then you would start with patient 3 while the resident started with patient 4, giving yourself a chance to maintain flow in your virtual encounters while giving yourself the opportunity to review and check in, giving the resident some additional time. You may also choose in there to schedule some holds in your schedule so that you can actually join your resident on patient calls and do some direct virtual supervision. We'll talk a little bit about that in the next slide, or join them on calls. So next slide, please. So just as in an in-clinic visit, the virtual visit involves a triad. a learner, a patient, and a supervisor. So the learner-patient interactions, obviously the learner is going to, have a patient visit. But what do we do in our clinic on the learner-supervisor side? Well, the learner-supervisor side, we usually do two types of interactions. And this is typically when the learner steps out of the room, or we have a private conversation with them, a sidebar conversation. We're usually either providing context before a visit, we are providing coaching during a visit, or we're providing feedback after the visit. Similarly, we may actually have an interaction between the supervisor and the patient prior to the learner engaging, where you may introduce a learner to have patient comfort, or you may ensure that there's a mutual understanding at a close of a visit. So you may go in at the close of a visit to ensure there's mutual understanding. So let's stop and pause and think about how we can do this in a virtual world. So let's think for a moment about telemedicine. So telemedicine, you may have the learner start the visit on their own, have an interaction because you've provided context prior to that phone call. The learner would need to either have you join them on the call. So I've done that a few ways in my own practice. So either if we're together in the same clinical space, I can sit in the room on a three-way call and listen to the interaction. So it's just on speaker, and then they place the person on hold to review with me briefly in the same room. Or you can have the resident three-way call you in on your phone and add you to the call, and you can be present for part or all of that call. Or you can have the resident text you while they're on a call asynchronously. Similarly, for a virtual care visit, we use the Well Health platform. It allows us to have family meetings. So basically the learner invites the supervisor in as an invited guest into the visit. We can turn off of our camera and just listen to the interaction. And if we're going to provide context or feedback, we're going to have to step away from that. Alternately, we could invite the resident into one of our encounters, introduce them to a patient, and then turn off our camera and let them have the interaction. Obviously, when we're doing this is new to patients as well. So we're going to need to get consent, and everyone's going to need to understand what's happening at all parts of the visit. So next slide, please. So that leads to the next thing, which is consent. So consent, obviously, when you think about the virtual care playbook and when we think about the CMPA, the things that they've put out to us, they talk about various tools and templates that many of our hospitals or institutions have taken up so that patients understand the limitations and risks associated with virtual care as well as the benefits. I think it's important if you're involving a learner to also have them understand explicitly what the role of the learner will be in their care, how that learner will interact with their supervisor in the virtual environment, and making sure that the patient understands who the MRP is. Because the virtual environment's a little bit different and patients aren't coming into a physical space to understand I am in X hospital, going in X clinic, and seeing Y physician for this. So really having the resident ensure that they're clear about my supervisor, who is the physician who's taking care of you and who will continue to take care of you, is Dr. X. And I'm a student working with them. I'm going to be chatting with you today. Is that okay? Run through the template. When we're done, or when we're done discussing, I'm going to take time to talk to my supervisor. I may disconnect the phone. I'm going to hang up, and can I call you back in 10 minutes time just to confirm the plan when we're done that? Next page. So obviously the other part of the visit that's super important is documentation. So discussing clear and timely documentation standards with your learner, you can reassure them that gathering the history is the same as it is in person. Just remind them that they need to be in a private area, and have them ask the patient if they're in a private area, giving them time to move there if they need to move there. Using headphones when they're in their visit to avoid unintentional oversharing with other people in the space. And remind them that they can document during the visit, but to have good website manners. So not documenting like this during the visit, but they can document during the visit. cue them to the bandwidth and signal strength. So don't ask multiple questions in a row. Give space for questions, ask one question at a time, and give them clear instructions how to contact their MRP for follow-up. Remember that when you're done the encounter, you have to close out the encounter properly on whatever platform you're using so that it doesn't either continue to broadcast or occupy bandwidth. Next slide. And once you've done all that and you've had a successful visit, it's so incredibly important to give your learner feedback and assessment, which will be covered on our next talk on July 23rd. Here's my references, and I think they were circulated as well as a PDF that you guys can look at.